led by Dr. Rahul Kothari also. The topic is very, very interesting. War and evolution of medicine. These are seemingly opposite events. The war destroys, hurts, depresses, and the medicine has healing touch for the hurt and injuries. How they can be still interconnected? Let me walk you through the timeline and let us start from ancient literature. Whether war and was there any need of backup medical facilities which got evolved later on? War means injuries, so need of backup facilities were necessary. References of medical backup in war led to Rigveda also. The foot of Vispala, the wife of Khela, was cut off like the wing of bird in battle at night. She was given a metallic leg so that she might walk. Khela is the name of the king. Agastya was a doctor. And the description of Rigveda about the prosthesis is what is depicted in this image. Let's go to Ramayana. Lakshman became unconscious along with many Vanar. So Sushen doctor advised Sanjeevani Bhuti to be brought from Donagiri in Himalayas. Sanjeevani Bhuti, the description is a radiolucent vanaspati. But Hanuman couldn't identify exactly, so he brought whole pharmacy down for the selection of the Bhuti. When we go further, in Mahabharata, when Bhishma fell down on arrow bed, this shlok which is shown over here says, as Sanjaya said, surgeons well trained and skilled in plucking out of arrows. So they were called over there to treat Bhishma. Bhishma declined it to take their help. But that means that physicians and surgeons were available on the battlefield so that they can immediately reach Bhishma. This is in Bhishma Paru. That's how we know that war and medical facilities, medical history go hand in hand. So let us go and touch the archaeological findings. One prosthesis was found dated 5th Egyptian dynasty, long time back. And Roman prosthesis was also found 300 BC, which had wooden core, bronze shin with leather straps. In 15th century, German knight was given artificial hand. One should certainly mention about Ambroise Paré, who in 15th century, in fact, introduced amputation for devastated limb. And also he introduced artificial joint in the construction of the prosthesis. Le Petit Laurent's hand made of iron that operated by springs and catches was very popular at that time. In the next century, also you can see in American Civil War, the mention of 30,000 amputees were resulted because of battle injuries. And they were also in need of prosthesis. The evolution of prosthesis is also one of the indicator how evolution of medicine occurs. Like there was a development of rubber hand, body socket, muscle contraction assisted prosthesis, so on and so forth. Nowadays, microprocessors are there. As we are on the prosthesis, in World Wars, it was the first time an emphasis was given that when the soldiers return home, how will they lead a normal life? And that's how physiotherapy, occupational therapy, it was needed there, and that's how it was evolved. Rehabilitation came into focus and it got evolved. Before the First World War, this was totally ignored. I have seen many organizations like Handicap International providing these supports in my missions in Syria, Yemen, and Iraq with Doctors Without Borders. Definite advantage was also there for doctors. As Hippocrates wrote, a surgeon should join an army and follow it. And since there was a need of doctors, the Caesar also formed a medical corps. We should mention certainly that Roman surgeons tried ligatures and clamping of arteries at mechanical hemostasis. And also boiling oil was also used as thermal hemostasis. They used vinegar as an antiseptic also. Galen was a very dynamic surgeon, bold surgeon. So he has great knowledge of human anatomy as well. As we mentioned about the French army surgeon, Louis Petit, his invention of the screw tourniquet, which you can see in this image, enabled the surgeons to do amputation without blood loss. So that became a necessary in every military surgeon's kit. Another adjacent image which you can see is of the drug kit what soldiers used to carry with them. Now let us come to an important mention. Dr. Dominic Larrey, a surgeon from Napoleon's Imperial Guard. Many remarkable ideas were implemented by him. He organized system for transporting wounded so that medical care is accessible in a timely manner. So, Dr. Larrey transported wagons into mobile hospitals with a medical team with that, and they used to call it flying ambulance, considering the speed at that time. This was really remarkable for that. He also introduced the concept of triage. Interestingly, Dr. Larrey sorted the casualties according to severity of the injury, and he did not take rank into consideration. This was drastically different from how injuries were treated before, as officers of higher ranks were treated first and lower of those persons with lower rank with severe injuries were treated later on. Interestingly, he treated soldiers in any uniform. That means he treated enemy soldiers also who were wounded. Now his story goes like this. He got shot in Waterloo and he became prisoner by Prussians. But their general recognized him because he recollected that his son was treated and saved by Dr. Larrey. So with honor, he escorted Dr. Larrey to Belgium. That is an interesting story indeed. This articulation of the shoulder, the technique which he developed, was very well known for years together. He also knew that death in war does not happen only because of arrows or because of arms, but because of infectious diseases also. So in that time also, he learned to quarantine the sick. This is how different concepts were used in Napoleon's imperial army. What he mentioned about the triage is now got evolved very, very nicely. It involves a color coding of the skin using red, yellow, green, white, and black ties. These are called triage tags. These are done by nurses or skilled professionals. Quick and expert assessment is necessary to start. Then detailed examination and management that later on follows. The red tag is for the immediate treatment whenever there is a threat to life, limb, or organ. Then comes the significant injury, but patients can wait for some time for the treatment. They have yellow tags, green tags for the minimal or minor things, and dead was given the black one. Black was for the dead. But now what is the sequence for them? Those expectants who are not dead, like maybe the burst abdomen because of a bomb blast or open skull also, the expectants consider transport and care later on. What you see in the adjacent image is the ICMR protocol of hospital triage training, which we used to carry out on all the missions. the training of the persons, checking of the equipments, who will stand where, who will work where. And that drill we used to carry out almost every week whenever there is used to be a less load. Now, the triage is a very well-known fact, recognized by all the healthcare workers because of the tag color, and it is carried out in civil areas as well for the mass casualties. Another thing which Dr. Larry has conceptualized was the horse-driven flying ambulance. It also got evolved in patient transports because each understanding led to a better and faster transportation, like a golden hour management or like the management of the hemorrhagic shock or something of that sort. So as the war advanced, the same way the ambulances also changed their speeds. Initially they were hand-driven or horse-driven, then it was motor-driven. The Korean and Vietnam War used helicopters for battlefield evacuation, and in fact that saved many casualties there. Now these ambulances will bring to the field stations all these injured. Now fields, there has to be evolution of the field hospitals. These are the crude field stations which you can see from World War I. And gradually the field and emergency management improved, getting more and more organized with standardized equipment. And that's how this has really helped in many, to save many patients over there. Then there was in World War II, there was an evolution to Mobile Auxiliary Surgical Hospital or MASH that saved lives in Korea also, in Vietnam. There's a TV series also there was. The idea for MASH, however, originated in World War II with Boston chest surgeon Colonel Edward Churchill, who in 1943 moved his best surgeons forward into rudimentary auxiliary field hospitals during the invasion of Italy. So expertise reached where it was needed most, that is on the battlefield. I can't resist myself but to show you this one, because this is the further evolution of the field hospital which I have worked over there. In 2017, saw a longest civil battle to take over ISIS governed Mosul by USA and Iran. Resultant victory came with the devastation of the Mosul city. Here, because of the continuous bombing and the war, wounded could not come out for months together and their neglected trauma. So Medicine Sans Frontier, as Doctors Without Borders, thought of starting the reconstructive surgery hospital of this old injury in this totally devastated city with no intact building for creating a hospital. So hospital in container was a great choice. So it has 5 containers with 1 OT, 1 recovery and other backup, including generator and many other things. It used to have ready 100 surgery kits till the next thing arrives. Those you can use, next help arrives. It can be installed anywhere, and within 3 hours it can be activated. This is a container of operation theatre where I will work in that compact container, but very well controlled. Sterilization and infection control was carried out, as you can see me operating over in that room. Another benefit was easily available. X-ray was discovered 20 years ago before the World War. First, few hospitals also had X-ray machines, but because of increased demands, manufacturing was increased. Government wanted to buy them, and so mobile X-ray unit was also started. So what had happened is that helped and improved the success rate of surgeries in removing deeply lodged bullets and sharp drills, which would otherwise have caused fatal infections or fatal injuries. Bomb blast and chemical always gives burns. So burns management was also needed. So it got evolved as different wars we had different weaponry to kill or injure persons. Advances in burn care occurred mainly in Vietnam War. They started using antiseptic and antibiotic impregnated dressings that helped reduce infections. Also, another life-threatening was an issue of excessive loss of body fluids in burns. So there was a better understanding of, so that led to better fluid management of these patients, added to better survival and recovery. Interestingly, the nutrition was also considered as the management of burns was evolved, and mainly in World War II and further. Now we're on the shock about this. This is considered the non-hemorrhagic shock. Hot and humid climate of Vietnam, soldiers used to get severely dehydrated, leading to body fluid loss. So as you can see here, the oral liberal use of balanced salt solutions, that's to call Gatorade, started. But here also, they started acclimatizing the troops over 3-7 days on the ship only in a what he called artificially created humid climate and hot climate. So acclimatize, after that, they won't get any this type of dehydration in Vietnam. So acclimatization medicine also got evolved this way. Introduction of IV fluids for the management of non-hemorrhagic shock was also one of the evolution in World War II. Now, what the hemorrhagic shock? Harvey had already proved that the blood circulates. Blood groups were discovered in 1901 by Landsteiner, so that the transfusions became successful. During the First World War, vast amounts of blood were required, but on-the-spot donors were impractical. So what was needed? A better method of storage and better methods of transfusions. You can see the adjacent image, the transfusion set, which was a necessary thing in most of the field hospitals. Vietnam War produced a number of important advances in the use of frozen blood products. Primarily, transfusions were used to treat severe hemorrhages and shock, as we understand. But it was also used for carbon monoxide poisoning and wound infection. In septicemia, there are some old practitioners in the audience. They might remember the use of fresh whole blood for leukocytes in septicemia when advanced antibiotics were not available. So, since we are on the blood transfusions, let us think the evolution of the blood banks because of war. Because of understanding of shock, availability of blood and frozen blood and components, what was required is the blood bank, because war never knows when is the next huge demand of the blood. Here, the great organization Red Cross assumed a leadership role and created a network of blood banks, not only for the war, but also in the civil area for the collection of the blood. That is a very important advancement for the survival of the soldiers. As you can see here, this is the top in one of my Yemen mission, where the cross is also written, and this is the crescent. Because in Middle East Muslim countries, the Red Cross is not recognized. So the same organization works under Red Crescent name. But since few Jewish people thought that both of the things, they still have some religious color. So now, recently, few years ago, even the red crystal is accepted had a logo of ICMR. All three are working. Very interesting story. For the mass killing, poisonous gases were used in almost all the wars. So gas masks were provided there, but still there were burns, there were injuries to the soldiers and civilians were there. Chlorine and mustard gas caused a lot of injuries over there. But however, what had happened? The exposure to mustard gas in World War I led to the observation of those alkylating agents causing bone marrow depression and also lymphoid hypoplasia, which was studied further in World War II. This observation led to direct application of such agents to patients with Hodgkin's diseases and lymphocytic lymphoma at Yale's Cancer Center. So this is how the different story from war, the evolution of chemotherapy for cancer treatment occurred. Another important thing was the World War I as a birth of plastic surgery. As you know, the bombs and bullets, they really devastate whole body, also face. So Gillies in 1916 started a plastic surgery unit at Cambridge. He described it as a strange new art. And he developed also of medical illustration techniques and sketches and really worked over there. Interestingly, he also agreed to that this is based on the work by Sushruta 26,000 years ago about his rhinoplasty techniques, which is Nasasandan, Ushtasandan, and Karnasandan. This image is from the translation of Sushruta Samhita about the same flap which Gillies did in the World War II. It is a very, very interesting story how the exchange of knowledge, when it's spread, helps the world population. Now, facial reconstruction surgery for the shattered jaws and nose. Here, it was started by surgeons at the American Hospital and Waldegrave Hospital. They pioneered maxillofacial techniques. At the same time, it was a need of dental surgery. So dentistry was also evolved along with facial-maxillary surgery in France in this wartime to treat injured soldiers. What happened about the anesthesia? As you can see the image on the timeline, most of the things were easily available before that also, but it was used sparingly at different hospitals. But its mass scale use was certainly done and then calibrated in war injuries of different war. Here, George Crowley introduced anesthesia as he had developed in Cleveland. In January 1915, he brought with him 18 large cylinders, 3,000 gallons of nitrous oxide, and did the anesthesia demonstration on surgical patient using nitrous oxide and oxygen mix to Carrel and Dakin and other French surgeons. Other things like ether and other things were also used, and gradually it was introduced and got evolved. In the war injuries which I treated, nowadays the anesthesia use is either the local blocks or ketamine or what is necessary over there. It also got evolved because we got hold of different type of equipments may be introduced on the field line. Fractures. In 1914, 80% of the soldiers with fracture femur used to die. As you all know, that when there's a fracture femur, there's a loss of 1.5 liters of blood, even if it is not compound, out of circulation of 5 liters of normal circulatory volume. But what happened within 2-3 years? 1916, 80% of the soldiers suffering from that injury survived due to the use of HOM-3. That is a stabilization of fracture. What is so important about that? So from mortality to morbidity as a first step in fracture femur was carried out. Thomas had designed a splint for TB spine, but in fact he knew that it will be very helpful for fractures as well, femur, around the knee, and tibia also. In fact, he had shown the technique to the war hospitals, but it was rejected. But it was later on widely popularized by Robert Jones, and that has helped. As you can see in another image, that different type of tractions are used so that the alignment is better on fractures, and that's how the orthopedic surgery started getting evolved. There has to be a mention of the use of metal plates and nails. Kunschner, he was an orthopedic surgeon in Germany. He developed Kunschner nailing, and even at that time in World War II, he had done closed nailing, not the open nailing, mind you. And that used to give stability to the bone, early mobilization, no stiffness of the joints, and injured German soldiers used to resume their duty earlier. What had happened when British had captured certain German prisoners? They, after taking history, realized they had resumed their duty within within 2 months or so. So they excelled, and that's how they came to know about this technique. In fact, Kushner, along with Marx, has already written this book, which became very popular for the stabilization. So different stabilization techniques were used for the early recovery. External fixators are very, very widely used, as I had used in all the 3 different missions. Because of the open injury, we don't ever do implant in open injury. It has to be external fixation that still exists. But now there are many modular external fixators available. Now that injured soldier has to go back and do his work with hand. But when hand is also injured, how to do about that? Sterling Bunnell had already written a book on surgery of the hand. So he was called upon by Surgeon General Kirk to create US Army Hand Center in 1944. He not only developed that, but he trained scores of surgeons in this subspecialty so that the injured soldiers can work back and gain their day-to-day living. Antiseptic and wound. You know, history is a story of stupid mistakes, analysis of those mistakes, thinking about it, and then creativity. What had happened? Theodore Tuffier, a leading French surgeon, testified in 1915, World War I, to the Academy of Medicine that 70% of amputations were due to infection and not to the initial injury. The usual antiseptics had failed. Here, another British biochemist, Henry Dakin, who perfected a solution of sodium hypochlorite. The Carroll surgeon started irrigating the wounds with this solution, which the image you can see with using multiple tubes putting in the wounds. At that time, and this slogan still continues to be true, solution for infection is dilution. That's how the doctors went and it got evolved from amputations to stabilization, then using antiseptics, and then repairing the rot by artilleries. How this happened alone? Because initially also there were these inventions were existing. This is only because the governments realized the urgency and responded and funded the research and production. We should certainly consider this to be a legacy of World War II by bringing government's attention for this. Now, you have already witnessed the international, not only national, international medical response in war against COVID. As you can see, there was an exchange of knowledge, understanding of autopsy results in Italy, early results of different management protocol, so on and so forth. But I should give a good example how penicillin got evolved because of the national medical response. Because in 1928, Fleming had discovered the penicillin, that mold killed the germs. He wrote an article but published them in a book in an obscure name. Book's name was very obscure. Sorry. But the Chen and Florey began research in Oxford. They started experimenting with mice. Penicillin was first tested on human beings in Oxford only. But mainly the US government and British government funded the production so that enough penicillin is produced to treat all the allied forces. This is how the coordinated efforts, focused efforts, helped the development of antibiotics. Sulfa drugs were also started that way, and many other antibiotics. This is as far as the wounds are concerned on the body. Now we should certainly take into consideration how were soldiers cared for after the war had ended. Many of them were physically handicapped, many of them were depressed, not only because of handicap, but psychologically also. Shell shock was a term used at that time, and we now call it post-traumatic stress disorder. Sadly, because those shell-shocked soldiers were not going to fight the enemy, many times they were court-martialed before that, but after realizing this PTSD, there was a good justice and management of this was offered to them and still continues to do that. Nursing, evolution of nursing because of war. In 1854, during Crimean War, British government requested Nightingale's and her aid at military hospital in Turkey. Within weeks of her small team arriving, the mortality rate of British soldiers fell dramatically. And this had a great impact, realizing the need of nursing in field hospitals. This is how the evolution of the nursing profession occurred. This accelerated a decade later during American Civil War. As fighting erupted in both North and South, women, mostly the mistresses and wives of soldiers, began following armies. They primarily tended to troops who are sick because of pneumonia, typhoid, diarrhea, other diseases. But the first formal training program opened in late 19th century. But now you understand there are skilled nurses who can do triage so expertly that you will also be surprised about their clinical acumen. Now about data and analysis has always given us the exact causes. As you can see here, out of total 70,000 deaths in Revolutionary War, 90% were due to diseases. In British wars, the death, 85% were because of the diseases and not because of the war injuries. In Civil War, 75%. Same was this in World Wars. So those causes need to be certainly managed. So what was done? Diseases and not arrows, bullets, or bombs killed more people. That is a realization. So generals have long understood the importance of sanitation to the health of their troops. The French army instituted physical exams for new soldiers and also those soldiers working in early 18th centuries. And this was spread in all European armies as well. In 1777, George Washington successfully inoculated his army against smallpox, demonstrating the value and efficacy of that public health intervention. Walter Reed started typhoid and yellow fever immunization during Spanish-American War and aftermath. As you can see over here, the troops is lined and the healthcare workers are immunizing the troops. But what had happened? Soldiers became more disciplined about hygiene and health and immunization. And that's how the public also became aware. So public health also got evolved because of this war-induced understanding. Nowadays, we are very much aware of evidence-based management. So that requires documentation. I am giving only one example of Vietnam Vascular Registry, which was started by military surgeon Norman Rich. As you understand, in a popliteal artery tear, in a ghastly injury, the amputation was the only outcome. But when it is only torn out, why to amputate? So vein graft was started being used. But how is the result of different procedures of using this? So this is how the registry invited and 600 surgeons and with contributed 8,000 vascular wound cases. And that's how the many papers came into publication from war hospitals. This is really interesting because this is with good documentation and good follow. But friends, now there is a changing scenario. Man-to-man frontal combat is now much less, which is overtaken by long-distance attack. And those long-distance attack kills civilians. As you can understand, World War I, 6 million civilians were died out of 15 million dead. World War II, 35 million civilians were dead, which includes Hiroshima, Nagasaki deaths and also genocides of Jews. And only 20 million military fatalities were. So this is how we should really understand that even though we practice in civil areas, we should have a relevant knowledge about these issues as well. As anthrax, biological war, COVID, some claim it was a biological war. So who were affected? Mainly civilians. So these are also biological war. So that also induces and affects the medical practices. Medical ethics were important from Sushruta and Hippocrates also. But the new points were emerged. If a military doctor encountered an injured enemy soldier, they had a duty under Geneva Convention to render medical assistance. Now, what about treatment of injured terrorists nowadays? Still on humanitarian ground, they should be treated. MSF had also considers that the term terrorism has political and ideological connotations that blur the boundaries. So better to stand for the medical neutrality. So we understand that doctors should treat all patients, all such patients. But sadly, the hospitals are targeted. I was on Yemen mission at that time. Few of the mission hospitals run by MSF were targeted by Saudi Arabia police. Saudi then apologized, but still, this is the truth. that each country or the group make an effort to stop help to the opponents. Another ethical issue of Nazi human experimentation. They conducted a series of medical experiments on large numbers of prisoners, including children, in concentration camps, World War II or Holocaust also. One of them was experiments on twin. There were more than 2,000 twin pairs were taken into consideration in concentration camp. One of the twin was experimented, as you can see down, different experiments to were lethal. And after the death of that one of the twin, another was killed to have a comparative autopsy. And most of the things they were done without anesthesia, which resulted in death, trauma, disfigurement, or permanent disability. This is absolutely medical torture. This is absolutely a scientific fraud. But in response to this, there was so much of discussions, like Dr. Leo Alexander, along with others from American Medical Association representatives, drafted a 10-point memorandum entitled Permissible Medical Experiments that went on to be known as Nuremberg trial. The Nuremberg Code. This code calls for such standards as voluntary consent of patient, avoidance of unnecessary pain and suffering, and that there must be belief that the experimentation will not end in death or disability. All medical councils of all over the world have included all the points in their ethical guidelines. Friends, the war surgeries are actually providing medical care to war wounded patients. It's totally different. Operating on war injured is a different ball game. Treatment is more important than formalities like consent, signature, fitness for surgery, which are very important, in fact, or the requirement of blood transfusion. Just a moment. One should always master the management of extensive wound in limited resources, and one should act immediately. There is always a psychological impact, not to the patient also, but also to the doctors and healthcare workers who see these ghastly injuries. There is a definite difference between surgery in times of conflict and surgery in times of civilian practice. I had an opportunity to work in 3 different areas to treat war-wounded persons. Civil war between Syrian government and multiple groups. But there are 2 doctors were in over there. One is King Assad, who was a Britain-trained ophthalmic surgeon who was working against his own countrymen who were revolting. Another is the Al-Qaeda top leader, Al-Jawairi, who was a Cairo physician. But this is a rarity, absolutely. Because I have seen in all these 3 missions, the organizations like Medicine Sans Frontier, Doctors Without Borders or Red Cross and many other organizations with thousands of healthcare workers helping this issue. I was just only one of them. My second mission was in Yemen, which was an actual war zone. So even in today's era, there was limited resources because material supply cannot reach in time. So innovations and you yourself as a good resource, that was really the concept. And one needs to develop concentration to use yourself well in this unmatched, disturbed surroundings. In Mosul, when I reached in 2018, war was over, but it was a post-war sequel because many people could not come out in war and all those injuries were neglected. infected with deformity and defects. And that's why the MSF had developed a reconstructive surgery hospitals. How we interpret war and its effect, most of them are really bad. But as Dalai Lama says, that it is very rare or impossible that an event can be totally negative from all points of view. Thank you all for joining with me to know about the interconnected of events, that of hurting war and healing medicines. Thank you very much.
Thank you so much, sir, for the extremely fascinating lecture. It was extremely interesting to see how, despite war having all these negative connotations and bringing out the worst in humanity, still pushes us and drives us to innovate and to constantly come up with new solutions to the problems that we face during wartime. This has certainly made medical science progress so much, and it is extremely interesting to note how many of these innovations are still in use today in some form or the other. We will be taking questions now. So if anybody has any questions for Dr. Kelkar, please put them in the chat box so we may read them out and address them. Thank you.
I think they are shell shocked.
So we do have some comments here in the comment section. Dr. Parisad Damania ma'am is saying it is an excellent lecture. And Dr. Kadambi is saying it's extremely interesting to hear your personal experiences. We also have a comment from Dr. Sunil Pandya sir. He says that another important development was the development of the Surgeon General's Library in USA. This has now evolved into the world famous library at Bethesda, which is now an international resource. Likewise, there was also the development of the United States Army Medical Museum, which stored anatomical and pathological specimens showing the ill effects of war.
Yeah, it is an important one, certainly, and there are many such resources available. Uh, I just introduced few of the things which were I thought more impactful.
So, we also have a question by Dr. Upadhyay. He asks you how you were equipped to withstand the psychological trauma probable which is faced by you in your civil practice.
In civil practice,
Yes, so that's the question, sir.
I think the psychological trauma is almost the same wherever it is. Only the context changes. So, in my opinion, probably what is required is to our regular meditation practice, which I've been doing for years together. I think you're talking about the psychological trauma to the doctors, right?
Yes, sir. That's the question,
Yeah.
sir. So we also have a comment here by Dr. Milind Kulkarni. He says it was an excellent and very informative lecture, and there's a lot of historical perspective given for current era medical practices that were not known to many people. And he thanks you for the valuable and
Thank you.
informative lecture.
Thank you very much.
So, I myself had another question actually. So,
Uh,
I'm interested in the history of the Second World War, and
hmm,
during that time, in fact, I read a piece which said that medics in the Second World War were um, granted immunity from enemy fire, but under the Geneva Convention, they were also not allowed to bear any arms and weaponry.
right.
And if they did, they violated it and were liable to be shot if captured.
Yeah.
So, do these there's this truce of not directing fire at enemy at medics of the opposing forces in a battle zone still hold true today?
No, it doesn't. It doesn't because uh, one thing that we are not supposed to carry any weapons with us, that is for sure. But as I had mentioned, each country or any group, they don't want the other group or opponents to have any medical facility. And sometimes they feel their opponents are hiding in hospitals also. And that's how the Saudi had bombed in Yemen also. And also this is a similar thing had happened in Afghanistan on MSF missions, Red Cross missions as well. This is very unfortunate that these ethics are much more followed mainly by doctors and healthcare workers, but not by the conflicting parties.
So there's also two more questions. One is from Dr. Sunil Pandya, sir. He says, salutations to you, Dr. Kelkar. You also deserve applause for selfless services during the more recent wars. So this question to you is, was your family apprehensive as you went into the war zone each time?
Oh, yes. Family certainly was apprehensive, but my wife knew that we really want to contribute to the society. And this is like crossing our own limiting belief that, say, our culture says that, hey, Vishwachi Mazigar. So why to treat only the persons around us? That's why we conducted and treated the camps in all our Mizoram and Sikkim also, apart from Maharashtra. So why not cross it? That why only limit ये अपने देश का है, अपने ही religion का है वो treatment करना. That's why I chose myself to go over there. But as you mentioned, family is certainly apprehensive, and I really want to thank my family, my wife, Dr. Mrinalini, so that she allowed me to go over there. Maybe not with total will, but just to follow my dreams to serve over there.
So there's also one other question by Dr. Nilima Kadambi, ma'am. She asks, what was the most challenging surgery performed or situation that you have faced in your work with Doctors Without Borders?
See, most of the surgeries, what we do is for the open wounds over there. Only the context changes. I mean, sometimes you feel psychologically hurt. Like when the two kids were playing ball and they landed on the landmine, and very small kids, and when they came late at night, bleeding, you have to just first stabilize, treat them, and at that time you don't. I mean, then next time another kid comes, you feel frustrated many times that you are doing good job, but they people and the nations are not realizing what is good for you. That is psychologically frustrating. The challenging surgery is basically you operate even if there is blood transfusion is not very easily available, or you are trying desperately to first save life and the limbs. So most of the things are very complicated things. Another challenging issue was the post-war sequelae, which I had a number of patients which I operated in Mosul. They were neglected cases, and that was mainly psychological disturbing rather than challenging as far as a surgeon is concerned. This I want to share with you.
Thank you so much, sir. I think we'll conclude the meeting right now.
Yeah, yeah.
It has been a pleasure to have you speak with us, sir, today. Thank you so much for accepting our invitation. We would also
This
like
is
to
my
extend
pleasure.
thanks. Also like to extend thanks to the audience who's attended here today, and we're extremely pleased you chose to join us in this Saturday evening. Next Saturday, that is to say on the 8th of October, we have Dr. Mridula Ramana who's going to be speaking to us about pandemic and epidemic history and the lessons we have learned from there. We hope to see all of you there. Thank you so much.
Thank you and good night. Thank you.
Good night, sir.